Good morning. Good morning and welcome to the first session of our 2018 Palliative Care and Geriatrics Grand Rounds. I'm Biara Dobman, I'm the course director, and it's wonderful to be connected again with colleagues near and far, old and new. So welcome to the Palliative Care and the Geriatrics folks here in the Ether Dome, to all those at Dana-Farber, to our new fellows who haven't experienced Grand Rounds before, to our colleagues at Care Dimension, and all of those at Cooley Dickinson joining from afar. So it's a large virtual family. It's my pleasure today to introduce our speakers. Dr. Michael Parsons joined the Pappas Neuro-Oncology Center in the Department of Psychiatry in 2017. He has 20 years of experience as a neuropsychologist and has specialized in the area of cancer and cognition for the past 10 years. He provides neuropsychological evaluations for adults with cancer, addressing the cognitive issues that are caused by cancer and its treatment. These evaluations assist in diagnosis and treatment of medical and psychological conditions that affect brain function. His research involves the use of cognitive assessments and advanced brain imaging techniques to study the brain. Dr. Parsons is a diplomate of the American Board of Clinical Neuropsychology and the American Board of Professional Psychology. And Dr. Jorg Dietrich is director of the Cancer and Neurotoxicology Clinic and Brain Repair Research Program here at the MGH Cancer Center, an attending physician at MGH and assistant professor of neurology at Harvard Medical School. His clinical interests are management of patients with benign and malignant brain tumors and neurologic complications of cancer therapy, including toxicity from radiation and chemotherapy. His research activities include clinical and translational basic research in the fields of brain tumor biology, biomarkers of cancer, neurotoxicity from cancer therapies, and brain repair mechanisms. Dr. Dietrich is the author of over 150 publications, including original research articles, review papers, book chapters, and other scientific contributions. His work has been supported by the National Institute of Health, the American Cancer Society, the American Academy of Neurology, and other foundations. Please join me in welcoming Dr. Parsons and Dr. Dietrich.
Well, thank you, BR, and thank you, Dr. Jackson and the Palliative Care and Geriatrics departments for having us here in the Ether Dome this morning. That's on behalf of both Dr. Dietrich and myself. My name is Michael Parsons, and as BR said, I'm a neuropsychologist, part of the Neuro-Oncology Center. I do serve as a consultant as my one disclosure, though it's not relevant to today's talk. What we are going to talk about today are cognitive issues in patients with cancer. And although the objectives that you have in front of you focus primarily on the underlying mechanisms, the topics that we're going to discuss will cover not only those core mechanisms, but also some details regarding available treatments and particularly a focus on what is in the pipeline for development in the future of treatment for cognitive issues in cancer. Now, you can't start a discussion about cognition in cancer without addressing the term chemobrain. And this is the only slide where you'll see the term chemobrain, within my slides at least. Although it's perhaps a losing battle, I prefer the slightly awkward term of cancer-related cognitive impairment. And I'll make the reasoning for that clear in just a moment. I think within this audience, within palliative care and geriatrics, the debate or controversy about chemobrain is perhaps less of a critical topic to discuss. I think those of us who care long-term for patients who either have or have survived cancer recognize that there are changes in the way the brain works after going through that process for a variety of different reasons that we'll discuss today. So we're not going to get in any further detail to debating whether or not cognitive problems occur in the context of cancer. Instead, what I want to do is lay out for you some of the basic science, both in my case at a human level and in Dr. Dietrich's case at an animal level, that helps us understand what this problem looks like and the mechanisms that cause it to occur. So to start with, cognitive concerns in the context of cancer and chemotherapy have been discussed in the literature since as early as 1980 and before, but really studied in more careful methods since about the 1990s. In the early 2000s, there were several studies that improved the methodology behind trying to understand this problem. And I'm going to give you just a couple of examples here. The graph you see on the screen is from a study conducted in 2004 from the MD Anderson group. And it was pretty characteristic of these early studies. A small study conducted with 18 women who had invasive breast cancer and were treated with a combination chemotherapy regimen. And what was perhaps groundbreaking about this small study was they found that several of the patients, amounting to a third of their sample, demonstrated statistically significant cognitive impairments before they received chemotherapy. This was one of the first studies to try to set an individualized baseline of cognitive performance before treatment occurred, and raised the question of what could be contributing to this pre-existing cognitive deficit, if not chemotherapy. They then followed the patients after treatment with chemotherapy and demonstrated that there were further declines, illustrated by the black bars on the screen, in the areas particularly of recent memory and working memory, which I'll talk about those terms in just a moment. They followed the patients over a few months after treatment and found that about half of them improved in their cognitive performance, though some showed persistent deficits. A follow-up study slightly expanded on the sample size and used a very similar methodology in which they essentially tested patients at baseline prior to treatment with chemotherapy, but after diagnosis with invasive breast cancer. The patients then underwent combination chemotherapy, a variety of regimen, and were followed at what they called a short-term time point and then a long-term time point. Short-term being about 6 months after the initial baseline, after 4 cycles of treatment, and then the long-term time point was about 6 months after the completion of treatment, or about 18 months from baseline. And again, they found that a proportion of the patients, in this case about a fifth, had some cognitive impairment before they were ever treated with chemotherapy. Over time, there were declines during treatment, shown on the left graph, in areas of recent memory particularly, and executive function to a less common degree. And further declines, again shown by black bars, showing further decline in memory after the long-term time point. So those are declines relative to the during treatment testing. That raised the question now of, is it possible that even after the cessation of chemotherapy, some patients go on to experience progressive worsening of their cognitive function for some reason? Now, over time, this literature has ballooned. The number of studies conducted into looking at cognitive function chemotherapy in the last decade has expanded exponentially. And the number of reviews of that literature has expanded perhaps even faster. In fact, one of the discussions we often have in our research groups is the fact that our field has about as many reviews as original research studies, which is not a great sign in terms of the amount of new research going on. Nonetheless, in the past 15 years, 10 different meta-analyses on this topic have been conducted. And out of those 10, 9 have clearly shown that there's some effect in one way or another. And each of these have looked at the literature in slightly different ways. The one meta-analysis that didn't took into consideration a variety of other factors. And it does show that essentially the effect sizes, the degree of cognitive impairment in many of these studies is small, what you might call subtle, but it is consistent for the most part. There's a group called the International Cognition and Cancer Task Force, the ICCTF, which meets every 2 years. In fact, unfortunately, you missed it. It was in Sydney this year. So if you pay attention and you want to go, it's in Denver in 2020 in the winter. So good skiing opportunity. It's a small group focused exclusively on the research into cognition and cancer relationships. And they have published 2 papers regarding the conduct of research in this area. The first of which in 2011 gave some guidelines for what kinds of cognitive assessments should be included in this research. to improve the productivity of research and the degree to which information can be combined across studies. Now, the next question you want to ask is, okay, we agree there's some cognitive changes going on. Which abilities are affected, and how does that relate to the underlying neuroanatomy? And there is some consensus within the field in a few different areas that seem to be most vulnerable. Working memory is one of those, which I mentioned earlier, which refers to the ability to hold information in mind. Working memory is the kind of memory you use if I give you a phone number and you have to get your phone out and open the contacts and enter that. All that time you're holding that information in mind, the phone number, until you get it entered. But you don't have the intention of necessarily storing it in your own memory for later retrieval. That's as distinct from recent memory, which has more to do with this kind of storage of information. Recent memory refers to your ability to retain a conversation that you had yesterday or the details of a recent event, so forth. These two types of memory depend on distinct neurological systems. The working memory abilities depending on looping circuits between the frontal, parietal lobes, and subcortical regions, and recent memory depending upon the hippocampal formation and its connections to the basal forebrain and frontal lobes. Executive function is another cognitive domain that is frequently seen as affected in various cognitive tests. That includes a broad range of abilities that include things like reasoning, problem solving, multitasking, initiation, perseveration, and so forth. And broadly speaking, it's dependent on a wide range of frontal brain areas and their connections to subcortical and parietal lobes. And finally, information processing speed is sometimes seen as a deficit, which is really probably a cognitive index of the integrity of white matter fiber bundles throughout the brain. So the overlying implication then from these multiple cognitive domains is that there are multiple cortical and subcortical regions that seem to be involved. It is possible that there's a special vulnerability of the hippocampus based on the most prominent findings in recent memory, and it suggests that whatever is going on in the brain must have a diffuse etiology to affect this kind of wide range of cortical and subcortical systems. This hypothesis has been supported by a broad range of research in the past decade using neuroimaging studies in humans to look at both structural and functional changes in the brain. And I'm going to give you a couple of examples of these here. Again, this is a literature that's really exploded. This was one of the early structural imaging studies that essentially compared gray matter density in individual subjects, both scanned immediately before and then 1 month after the completion of a multi-agent chemotherapy regimen. And what Brenna McDonald and her colleagues found was that there were focal areas of decreased gray matter density, which essentially relates to cellular counts in those regions that occurred in the patients, and that same change was not seen in a matched control group that was also scanned at the same intervals. We mentioned the hippocampus earlier, and that's been a focus of anatomical and structural imaging research in and of itself. This was a cross-sectional study conducted by Shelley Kessler and her colleagues, essentially looking at patients who were scanned 5 years after completing a chemotherapy regimen and matching them to other similar individuals in terms of age, gender, and education level. And in comparing the chemotherapy-treated patients to the matched controls, they found that there were differences in hippocampal volume specifically, but not in any other areas of the gray matter when they compared these groups. And furthermore, when they correlated those hippocampal volumes, they found a relationship with memory test performance scores, suggesting that this is a functionally relevant change in brain volume. Further structural research has looked into the integrity of white matter using a number of different techniques. Diffusion tensor imaging is an MRI-based technique that measures the integrity of the large fiber bundles throughout the brain. And Sabine Deprez and her colleagues have probably done the best study of this following a number of patients longitudinally. They examined breast cancer patients in 3 groups, some who received, two breast cancer patient groups, some who did and some who did not receive chemotherapy, and compared them to another matched control group, all of whom were scanned longitudinally over time. And 2 things, one that's not highlighted on this slide, they found there were differences between the breast cancer groups and the control groups, both in terms of cognitive performance and white matter integrity at baseline before treatment with chemotherapy. And then there were further changes in memory and working memory within the group that was treated with chemotherapy, but not in the untreated group or the control group. Furthermore, those changes in cognition correlated with some reductions in white matter integrity seen here in the frontal lobes and in frontal and parietal white matter fiber bundles, as well as within these posterior fiber bundles in the occipital lobe. Those patients have since been followed now 6 years after this original study with a longitudinal design, and they have shown some improvement and recovery in this white matter finding in a paper that was published just last month. So in addition to structural brain changes, there have been a number of ways of looking at brain functional activity. In this study conducted by Dr. Dietrich and his team a few years ago, they went into the records of standard staging PET scans of a variety of cancer patients followed over the past 15 years here at MGH and compared brain glucose metabolism both prior to treatment with chemotherapy and then after completion of the first round of chemotherapy regimen, and showed a dramatic decrease in glucose metabolism throughout a variety of brain areas that was not seen in other areas of the body. So here you can see the comparison between brain metabolism and liver metabolism, which was minimally changed in those patients with chemotherapy. These changes were seen throughout the brain structure, but predominantly within gray matter areas. The other method of looking at brain functional activity that's often talked about is functional MRI. This was a clever early study that was conducted by Andy Sakin's group, where they took a patient and her identical twin, one of whom had developed breast cancer and been treated with chemotherapy, and asked them to complete the same battery of cognitive tests and functional brain imaging. What you can see in the image is that one of the 2 twins has a very different, more extensive pattern of brain activity than the other. And you might not guess this, but the twin who had the more cognitive difficulty, the one who was treated with chemotherapy and had cancer, is the one on the left. This demonstration is actually consistent with functional imaging findings in a wide variety of neurologic conditions in which we see a hyperactivation of brain areas that are often not directly related to task performance, almost as if it's a compensatory effort to recruit additional brain areas to perform the task. That same pattern of hyperactivation and altered activation has been demonstrated in a number of other studies, including this project by Shelley Kessler, in which she examined memory activation during performance of a memory task. And this is somewhat subtle, but essentially what she found here was that during the early stage of memory formation, which we call encoding or bringing information into memory, there was higher activation in the non-cancer patients. Whereas during the retrieval phase, there was greater activation in different areas in the cancer patients. A complicated finding with many potential interpretations, but demonstrating something is altered about brain activity that correlates with this cognitive deficit. Again, the International Cognition and Cancer Task Force has provided some guidance and recent guidelines in a paper published this year for the approaches to functional and structural imaging studies in this area to try to harmonize and improve the comparability of findings in a variety of ways. So I'm coming to the end of the first section of this talk, and I'm going to hand over to Dr. Dietrich here. But I think what I'd like you to take away from this section at this point is that there's clear evidence in well-controlled studies that there are cognitive changes occurring in the brain in the context of cancer, and further changes potentially occurring in response to chemotherapy that not only are seen on cognitive tests, but are also supported by structural and functional changes in the brain. What we now need to ask ourselves is, what do these findings tell us about the underlying cellular level pathology that might be going on? And that's where Dr. Dietrich is going to take the reins.
Okay, thank you very much again to have us here to, I think, give that opening grand rounds, which is a joint grand rounds I learned for the first time. So I hope we do a good job to address various audiences and aspects of what you care about. So by taking this forward, you learned a lot about a complex problem in medicine and also in the patients you see, which is that they complain of difficulties with memory and thinking, but it is hard to pinpoint where this is coming from. And so the studies suggest that there is a real issue, and where preclinical work comes into place to try to dissect which are the factors that really drive this problem and what can we do about it. And so you've heard a little bit about how perhaps cancer and treatments, which is chemotherapy, and in some patients radiation, can contribute to a cognitive decline. But I want to remind us that there are numerous other factors that play a role and that are dear to you, to your work, including sleep dysfunction, mood disorders, chronic fatigue syndromes, and we don't know how they all interact with each other and which one is the real driving force behind a symptom you may hear about and try to treat. And so some of the work has now been better understood based on about a decade or 15 years of preclinical studies. And before I get to that and summarize the field, I want to remind us also on two important brain areas that are relevant for brain plasticity and regeneration in adults. So as you are sitting here, you're forming new neurons on a daily basis, and there are certain things you can do about it to enhance that mechanism. And the two regions I want to highlight is the subventricular zone, so surrounding the anterior regions of the ventricular system. And this is here depicted in the rodent system. You see the sagittal section of cells that are born in that region and then travel along that rostral migratory stream to the olfactory bulb. So the rodent is critically dependent on an olfactory sense, much more as humans are. But we know already from a lot of work in the Alzheimer's field and dementia field that the olfactory sense is one of the first senses to go in patients with neurodegenerative diseases or taste. And then the second structure is below in the hippocampus, the dentate gyrus, where a high number of cells divide and proliferate and form new neurons that are integrated in existing networks. This is the human correlate of this, so it's highlighted in red, and in panel C you see the subventricular zone of critical importance, and then in D the hippocampal structure in the hippocampus and amygdala region where a lot of neural plasticity occurs. So earliest hints that there's an issue in patients treated with radiation came from studies from the early 2000s or late 1990s, showing that the level of neurogenesis is markedly decreased after radiation. So you have an impact on the overall regenerative potential in an adult after radiation, and this might be of very long-lasting effects. If you think about that, you wipe out a certain pool of cells that are there to rejuvenate and repair injury, and these are all gone, you will essentially have a picture of much accelerated aging. What we also found is from these earlier studies that vascular toxicity travels along with these. So radiation, if you ask a radiation oncologist, they all would acknowledge that the vasculature is one of these target tissues at risk after radiation. And then moving forward, this is actually from a cell biological standpoint a very important slide because it illustrates this intimate relationship between capillary systems in the brain, and rejuvenation. So they all cluster and go hand in hand. And if you have injury on vascular systems, you will suffer in terms of regeneration. Or if you just kill off the cells, the progenitor cells directly, and the vasculature might be intact, that also would lead to a very similar pattern and phenotype. So we asked one very basic question is, if you take common drugs, common chemotherapeutic agents, such as platinum, which is an alkylating drug, or BCNU is a nitrosourea, an old school chemo drug, how do they affect different cell types if you test them all in parallel? Is there any changes you can see and pan out? And so this is actually about 2 years of work, cumulatively in one slide, showing that when you line up various different key cell types, such as progenitor cells, stem cells in the brain, mature cell types, astrocytes, neurons, and you compare them to even the most sensitive cancer cells, you see one pattern, which is that the O2A, the oligodendrocyte precursor cell, and the oligodendrocytes, which are the myelin-forming cells in the brain, are the most vulnerable to any of these agents. And that's quite consistent and has puzzled us from the very beginning why the myelin-forming cells are so vulnerable to offending drugs such as chemotherapy. It gets even worse in the sense that long-term effects are visible after a number of months. So where you have thinning of the corpus callosum, which is one of the key structures of combining right and left hemisphere. This can be studied in electron microscopy, and these mice do actually have a deficit in myelin related impulse transmission. So you can use what you probably know as brainstem evoked potentials in mice as well, and use the hearing to demonstrate that there's a myelin deficit. So myelin is a problem, and even if you have no cell death in terms of neuronal injury, if myelin suffers throughout the brain, then the brain suffers, and you might have symptoms that Dr. Parsons illustrated from these early studies. So to summarize a little bit some of the early work, numerous authors and teams have now put on the map that essentially any major chemo drug that you looked at, including anti-hormonal treatments such as tamoxifen, have an impact on gliogenesis and neurogenesis in the brain to varying degrees. For me as a neuro-oncologist, to see the temozolomide as one of the key offenders is heartbreaking, because that's a drug we use on a daily basis. And I know from a lot of work scientifically that this is a very harmful drug to cells that are critical for memory formation and maintenance. So how does it all work together? In particular, if you think about it, it's not just all about chemotherapy. It's about environmental toxins we talk about and we hear in the news every day. It's about lead and mercury and heavy metals. It's about the vaccination story in kids. Should they get vaccinated or not? Or is it called autism that will be induced later on in life? So all of this merges into one topic, is that pro-oxidants engage in a pathway that ultimately degrades a receptor system, which is the receptor tyrosine kinases of the PDGF receptor, that sort of fades and degenerates and is the driving force for rejuvenation. So it is one of these key converging mechanisms that we have learned over the years, where a lot of different types of insults can have the same end result, which is degradation of the PDGF receptor, and hence division drops and cells die. So this is a key summary slide of mechanisms over the past 10, 15 years that have been identified. So besides direct cellular toxicity on the neuronal level, on glial level, and oligodendrocyte level, we have that dysfunctioning white matter network, which is a problem. And there are indirect mechanisms that play hand in hand with the above, which is vascular toxicity, in particular from radiation. It's a cytokine release syndrome of offending cytokines and small molecules that are pro-oxidative and exert pro-oxidative stresses, and there could be also inflammation as a result, in particular after radiation. And this is all on the backbone of various factors that are very difficult to control in the clinical setting, such as genetic factors or age or hormonal status and metabolism. So we all know that we have patients who get the same regimen and they do great. And they say, I feel 100%, I can work full time. And then you have the patient who gets the same drug and they say, I'm done. I have to sign out. I can't take care of my kids anymore. I forgot what my conversation was with my husband this morning. I forgot to pick him up from soccer. They are really struggling and have had exactly the same treatment as the one who has essentially no symptoms. So clinical practice, this is a case right out of our own clinic. White matter disease is common and it can be found just straight out of our floor when the patients are treated with methotrexate for lymphoma. You get a picture of subcortical diffuse white matter injury, and here are several examples. And when I show you this picture, you would say, well, it looks pretty much the same to me, and it kind of does, but this was purely after radiation. So this patient has not received chemotherapy for a brain tumor, but the end result is very similar. And what you also might appreciate is that the ventricular system is kind of a little large. That is not supposed to be like this. So we call this ventriculomegaly or hydrocephalus, communicating hydrocephalus. And here's a young guy that I treated with my colleagues, and he's still at Spalding Rehab after years. And he had been treated for a tumor that essentially was treatable, and he was cured from it, a medulloblastoma in the posterior fossa. But as an end result, he developed vascular injury. And you see these in the lower panel, all these black dots. So these are microbleeds. And if you look at the upper panel, you can get an appreciation of how much brain atrophy has occurred in this young individual over just 5 years. So this is kind of devastating to see and hard to anticipate and estimate how this individual would do by hitting the age of 40 or 50. So this is another story when we talk about success in neuro-oncology. We're all happy if a patient survives, in particular after treatment for glioblastoma, but the end result can be grim, which is a lot of cognitive issues, bleeding events, dead tissue in the brain, necrosis. So this individual has survived a glioblastoma for over 10 years, a fairly young guy at age 42. But he had, I think, a total of 3 surgeries to see whether additional tumor had grown, which was not the case. It was basically just damaged brain in the posterior regions, and the GRE sequence on the right gives you an idea of how much bleeding has occurred over the years. So the outlook is not always fantastic if a patient survives, and I think there is something we need to better understand and prevent from as an outcome. So we looked at this more systematically, knowing about that problem that Dr. Parsons had illustrated, that what we have seen in our patients and from animal work. And we looked in our glioblastoma patients just over a very short period of time prospectively, and found that over just about 6 weeks to 6 months, you have a traumatic expansion of the ventricular system. So brain atrophy occurs quite early and is progressive. And the number that we estimated from this cohort of patients was about 42% of expansion of ventricular volume. And one of these examples is shown on the right with the MRI. So this is quite shocking, actually, to see such a degree of changes in a very short period of time. And by looking now at white matter structures and gray matter structures and the ventricular system, we did see a consistent pattern over the years that is progressive, looking here at more than 450 days out, that gray matter and white matter volume is lost over time, and then the ventricular system expands. What we did not have with these patients would be something that we used Dr. Parsons' input, which is, do these patients actually exhibit neurocognitive symptoms? We see a lot of structural changes, but is it meaningful? When I submit a paper, many times reviewers get back and say, well, this is very fascinating, but does it have any impact? Does it mean anything to the patient? And so that's obviously the other side, is not always structural changes correlate with symptoms. And on the flip side, sometimes we have patients with a lot of symptoms where we just don't see a lot of structural changes. We looked at patients who also were not exposed to radiation at all. Here in a cohort of patients with underlying systemic lymphoma, just treated with bone marrow transplantation and high-dose chemotherapy. And you see a similar pattern of ventricular expansion and loss of white matter density in the corpus callosum. So this has intrigued a number of researchers, also part of this ICCTF group, to come up with a model to say, what does it all mean to us if we all age over time? And so I think geriatrics is one of the audiences today. Aging is obviously a factor that comes along with loss of brain volume and cognitive function. And so if we have, without a cancer here in this yellow line, your normal trajectory over lifetime, perhaps in a cancer survivor, you have shifted that curve to a lower level. So they are actually more vulnerable, but you could also have an accelerated aging from the mechanisms I just outlined. So you have a dropout of the cells that help to rejuvenate and rebuild, and hence aging is much more accelerated. This has now also been, this model used to incorporate frailty as a factor that is relevant to your work, where this curve could really change in its slope. And so you have really a much more dramatic aging pattern that we are trying to now understand with sophisticated advanced imaging, whether this is actually true or not. So what can we do about this? Some more good news stories. After all of this grim outlook of cancer treatment is bad for the brain, but there is exercise. So exercise is one of the driving forces of regeneration in the brain to enhance plasticity. Now, when you have a mouse running in these running wheels and you study this, they run essentially a marathon every day. And so we certainly would not advocate for us to do this. We are not built for running a marathon every day. But cardiovascular exercise is by far the most strongest stimulus that has been studied to enhance these rejuvenating mechanisms in the brain. So it's something that we should keep an eye on, in particular when we care about patients and how to help them moving forward. Another topic that is obvious from the literature is diet, aging, and cognition. And here we are on a daily basis and never talk about these issues with our patients. And I've been puzzled for decades why there's so much basic science literature on the issue of how cognitive function is related to what we eat and how we live, and yet we're just not able to incorporate this in our daily management. But there's a missed opportunity, I think, that will have to be picked up at some point. The literature is very strong in this regard, how antioxidant, healthy foods, caloric restriction, and other dietary interventions really decrease neuroinflammation, enhance regeneration, and prevent aging. These are some studies from animal work that have looked at antioxidants. For instance, N-acetylcysteine is one of the strongest ones. We know it's kind of driving the glutathione restoration system, is powerful and has been helpful in repairing damage from chemotherapy, as well as serotonin reuptake inhibitors. Perhaps you know that literature as much as I do, but these SSRIs are actually through serotonergic mechanisms driving neurogenesis. It takes about 6 weeks for the effect to kick in, and this is why it may take 6 weeks for your patients to have an effect on mood stabilization. So you don't really expect from an SSRI that started today to have a benefit tomorrow, but it typically takes weeks. So there's a lot of research in this regard of how SSRIs are driving brain plasticity. Exercise also has been studied in animal models with positive effects. And this is one of our most recent studies that just came out this year, where we identified something extremely surprising to us, which is that the bone marrow itself, so your own bone marrow, is one of the driving forces of brain regeneration. And it's something that can be easily, I think, taken advantage of in a clinical setting. There are factors that can boost bone marrow function. And these cells that are color-coded here and labeled can be tracked. You find them in various brain regions. They turn into microglia or monocyte macrophage dependent cell lineages or systems, and they go hand in hand with increased proliferation in neurogenic and gliogenic regions. So it's a fascinating mechanism that we all bear and has been sort of not really looked at in decades, and perhaps there's a nice avenue of moving forward as a positive intervention for patients. So how can we move from some of that basic science and translational science knowledge to the bedside? And here are these domains that I grouped them in a sense that exercise is an easy one where a patient intervention is feasible, has been well studied. We know what the mechanisms are, as well as dietary interventions. Sleep obviously is an important factor that you need to consider when you manage patients and evaluate them. If someone has cognitive issues and they just can't sleep, there's a first thing you have to consider to do before even thinking about other strategies. And other factors, unfortunately, we can't manipulate or change, which is genetic factors, but they can help us to assess patient risks. So if you have someone who has, let's say, the ApoE allele that drives dementias in some individuals, and that is a risk factor for cognitive decline, then you might have to be more cautious in what types of treatments you offer. You could say the lowest hanging fruit is just not offer treatments at all, and you spare them from toxicity, or at least modify the interventions. And one of them is that we try to avoid whole brain radiation therapy, or spare the areas that we know are so relevant, which is the hippocampal structure. So we call it hippocampal sparing radiation. And that is now being done in various institutions, including at Mass General Hospital and at the Brigham. And you can also perhaps think about whether proton radiation is sometimes safer to save particular eloquent brain areas. So there, in the radiation field, sort of easy interventions that have been implemented already. In terms of pharmacological interventions, you hear about neurostimulants, methylphenidate and modafinil, and Dr. Parsons will give you a little bit more on the ongoing clinical trials in this regard. But this gives you the flavor that antioxidants or erythropoietin, which stabilizes the red blood cell system and helps anemia to recover, anti-inflammatory agents, and cytoprotective drugs that are used in dementias have all been now implemented in our patient population. So patients with cancer have been treated with such agents with mixed success. Here's one of them that was endorsed by the AAN, the American Academy of Neurology, is to use memantine as an upfront agent in patients undergoing whole brain radiation therapy, as it had been shown to decrease the level of cognitive impairment that you will get down the road. Which was interesting for me from a physiological standpoint is that the exposure time was only about, I think, 24 weeks, but the effects were sustained over much longer. So it's really a certain time window that was considered extremely beneficial for that intervention. And we do it now here at MGH2. We offer our patients memantine prior to whole brain radiation therapy. So non-pharmacological interventions are key as well. And again, I tell you about the exercise or enriched environment that is so relevant for cell physiology of the brain and brain health. But you could also think about, from a very practical standpoint, to eliminate confounding factors, such if you have an endocrine dysfunction, like a thyroid disease that needs to be evaluated for and treated and corrected. If you have a sleeping disorder or a mood disorder, all of these need to go hand in hand and in parallel. So I don't want to simplify this, that this is all about the drugs that we give and cause cognitive issues. There are a lot of sort of construction areas acting in parallel that need to be addressed. And then cognitive rehab, Dr. Parsons will spend a few words on telling you about some of these interventions. It's never too late to start your exercise program. Here's Farah Singh at age 89 running his first marathon. And this is just an example that cardiovascular exercise is beneficial, and lots of important papers have been published in this field. This is one that caught my attention because it was in the group of malignant brain tumor patients. And this is out of Duke, where Lee Jones and colleagues identified that exercise behavior on its own is one of the strongest predictors of outcome. So it is something we, again, don't incorporate well. We look at molecular genetic factors, MGMT and IDH and yada, yada, and then tell patients, oh, you do well, but we don't really tell them, tell me about your exercise behavior, and then tell you how you will be doing down the road. what's intriguing to this topic is that in patients who are extremely fit, they will have less side effects from drugs. So pharmaceutical companies caught an eye on that and say, you know what, if we can incorporate an exercise paradigm, then our drugs will look better because they have less side effects and they just tolerate things. And so I think it's something that you can see from different angles of great benefit in moving forward. This is a study that was just published last year and is quite fascinating because this is out of Canada. A group, I think in Toronto, looked at whether kids treated for brain tumor more than 5 years out who had developed cognitive issues, and this is obviously a problem in kids a lot who are doing development when they get treated, have profound symptoms down the road, that whether an intervention, an exercise intervention could change outcome. And they had a crossover design of one group, no exercise, the other one group, yes exercise. They go, and after a certain period of time, they just cross over and assess. And what was quite fascinating to see is that they have increased white matter density, the exercise group, and increased hippocampal volume. So all the areas that I told you earlier about are of such important and such relevance in the brain. And that this effect actually fades away if you stop doing exercise. So it's something you need to keep on doing. And that allows me now to hand over a last time to my colleague, Dr. Parsons, to talk about cognitive interventions.
All right, thank you. So we have just a couple more slides and then there will be time for questions, but I think that no discussion about treatment for cognitive issues in cancer patients or other neurologic populations is really complete without describing cognitive rehabilitation effects. In fact, I see we have one of our cognitive rehab speech therapists here with us today. And essentially these fall into two broad categories. One is individual cognitive or group cognitive rehabilitation that is guided by a therapist, individualized for the patient. The other is using computerized tools to provide cognitive stimulation or exercise. And studies of both kinds of interventions have been done in the context of cancer. I'll give you again just a couple of examples of these. The first study listed here looked really at training two different cognitive abilities in different groups. One received training focused on learning new memory strategies driven by a cognitive rehabilitation therapist, and the other received training that was designed to improve processing speed on mental tasks. And both groups showed improvement in the domain in which they were trained, and the processing speed group also showed a little bit of improvement on the memory scores as well. And this brings up the issue of the transfer or generalizability of the cognitive activity you train to other activities, most importantly, cognitive functioning in everyday life. A similar study looked at memory and attention training to focus on that verbal recent memory that we talked about earlier compared to waitlist controls, and did show an improvement, again, on the kinds of cognitive tests that are being trained. Computerized cognitive training tools have been used in a couple of different studies. And again, without going into all the details of the design, essentially what we see is that some of these computerized cognitive tools produce improvements in the domain that is being trained, but the generalizability is limited, and there are some methodological issues with how you measure change in function over time when you naturally expect practice effects to occur on the tests that are being used to measure improvement. The most recent study of computerized cognitive training that I'm aware of followed a 15-week, pretty intensive cognitive exercise program, 4 days a week for 40 minutes at a time, kind of trying to parallel what our recommendations are for exercise, physical exercise, and included a variety of cognitive tasks, vision, attention, processing speed, and found that although patients reported an improvement in the way they felt cognitively, there really wasn't any measurable improvement in the treated group over a placebo group on cognitive tests themselves. So this comes to the issue of generalizability of the results. And I think the bottom line is that we know that cognitive training and cognitive stimulation is an important component of everyday life and improves brain health in general. But the results in terms of the computerized tests tell us that it may not matter that much what exactly you're doing cognitively, that you're doing some activity is probably the key ingredient. When individualizing your cognitive therapy for the patient, designing tools and techniques that are relevant to their everyday life issues is really the key ingredient that leads to success and improvement in functioning for patients. So to end with, I wanted to show you some information that Dr. Dietrich and I collected for a recent review. What's listed here are ongoing studies listed in clinicaltrials.org that are looking at the effects of various pharmacological agents in cognitive function for patients with cancer. And you can see there's a huge variety of drugs that are being explored, not only the cognitively stimulating drugs like attention enhancers and memory enhancers, but also a number of neuroprotective approaches that may incorporate exercise with the drug trial. And in non-pharmacological mechanisms, there's at least an equal, if not greater, number of ongoing trials that are looking at combinations of exercise, cognitive rehabilitation, and some more advanced neuroscientific methods, including transcranial direct current stimulation, which is an electrical stimulus applied to the scalp that is used to enhance cognitive performance in focused domains. So there are also a variety of alternative therapy approaches that are being explored, including using light therapy to improve circadian rhythm disorders and acupuncture and Tai Chi to address mechanisms at very different levels. The point of these slides is that this is an incredibly active area right now. Getting back to my original point that I think the debate about is chemo brain real is kind of over. And the field has moved to the point of saying what can be done about it, understanding there are, as Dr. Dietrich was pointing out, a huge variety of mechanisms that are contributing to this heterogeneous group of individual problems. And approaching this from multiple different angles is underway at the moment. So to summarize then, on the left side of your slide here, we have a variety of issues that can have a negative impact on brain health, neural regeneration, and neuroplasticity in the context of cancer. And those can include the treatments, inflammatory changes related to the underlying disease, and individual factors such as aging and genetic variables. And on the positive side, we now know there are a number of approaches that we can take to try to address these problems, including the lifestyle issues of exercise and diet, cognitive activity, and potentially neuroprotectants and other agents, as well as Dr. Dietrich's recent point about tools used to improve the health of the neurogenic niche and promote neurogenesis into adulthood. So with that, we'll stop, and I think that gives us a few minutes for 5 minutes or so for questions. Thank you very much for your attention, and again, thank you so much for having us here to talk to you today.
Thank you so much, Dr. Dietrich, Dr. Parsons, for such a rich presentation that's so relevant to our patient population. Open it up to questions here first and then remotely.
Thank you very much. Very interesting. I'm a social worker with palliative care and certainly know and hear a lot about chemo brain. I was curious about the hyperactivization slide. And I think I heard you say, many factors. And I was wondering how that slide might have looked if we could in some sort of way look at fear alone. And I wondered what your thought might be about both the value of fear as well as counterproductivity.
Interesting question. I think to put it in a little bit of context, this pattern of increased recruitment of widespread brain areas to perform a task is a common finding that's been shown in a variety of neurologic disorders. And there's a kind of a prominent theory that has been proposed to explain this process, and it's currently being evaluated, that has to do with essentially the degree to which an individual's neural structure and abilities might support that kind of recruitment. So a lot of that discussion is about neural structure as opposed to, say, emotional stimulus or activation. Essentially, fear, or more broadly, anxiety as a component, tends to serve as an interfering factor on a variety of cognitive tasks. And I don't think there's an easy answer as to how that would represent itself on functional brain activation studies. Certainly there's a whole literature looking at brain activity in the context of fear, and it's driven by many of the same structures that we know encode new memories, including the amygdala, hippocampus, and limbic circuitry. So many of the theories about the way in which depression and anxiety affect memory have to do with essentially kind of a hijacking of that circuitry to subserve fear processing as opposed to memory processing. But that is its whole own incredibly complicated literature that hasn't, I think, to my knowledge, been put together with the cancer-related cognitive impairment.
Any questions from Care Dimensions, Dana-Farber, or Cooley Dickinson? Any other questions here? All right.
Thank you very much. Great talk. I am a geriatric medicine physician and a palliative care physician, and I was wondering, not only medical, psychological, and social aspect, but any study or the management incorporating like existential suffering or spiritual suffering, because brain work with a lot of spiritual distress can definitely make their cognitive daily function worse. So I was wondering any way that how you actually control the study population, and also how are you seeing any management actually incorporating that spiritual and existential suffering aspect?
I think the issue of the interplay between emotional state, broadly speaking, whether that's spiritual, existential, just straight up anxiety or depression in the context of cancer, is a huge component of the chemo brain or cognitive impairment story. And I think that we focus today on the neurologic knowns and unknowns, but the psychological component is just as big a part of the picture. It's less well understood. So, for example, one of the things that I alluded to in talking about inconsistencies in the cognitive literature have to do with whether you measure a person's memory by asking them, are you having problems with memory, yes or no? We call that subjective memory impairment, versus whether you give them a test in which they have to memorize stuff, which we call performance-based or objective impairment. And it's well known that there's poor correlation between those two ways of measuring memory. So you have to read this study very carefully when they say memory impairment in cancer. We believe that some of those emotional factors have a huge impact on driving the subjective experience of memory loss and may not necessarily influence objective or performance-based memory testing to quite as distinct a degree. So currently, I'm working with some of the Cancer Outcomes Research Group team members to start to explore what are the psychological constructs that might help to understand which people are at psychological risk for experiencing cognitive impairment, whether they do or do not have cognitive impairment measured objectively. And your concept, your question about spiritual suffering, anxiety, existential state, what have you, may very well be important explanatory constructs. Elise Park has been working on the construct of resiliency in survivorship in cancer, and that's one that we're starting to just begin to explore right now. So a very interesting question that I don't know the answer to.
I may add one thing we didn't cover in this talk, which was actually stress is one of the core fundamental principles of impairing regeneration in the brain. So Liz Gould, for 15, 20 years, has driven this field with her work and others of identifying how stress and fear and anxiety impair neurogenesis and hence brain regeneration. So I think this is a very, very important topic, but for the matter of time, we had to sort of prioritize. But I just want to emphasize that there is a very strong literature in support of this being a contributing factor to the subjective symptoms that we encounter.
I think we'll end there. Thank you very much.